A very good morning to respected judges, juries. Today I am going to give a prepared presentation on correlation of Omicron and saliva, the magical fluid. This is Dr. Prateek Banerjee, pursuing Master of Dental Surgery from the Department of Public Health Dentistry. So today I'm going to focus on one of the most hot topic, that is the Omicron variant of Corona and its relation with that of saliva, the magical fluid. So why it's called the magical fluid? Because of its vast variety range of the physiological properties. It acts as a biocatalyst for digestion. It has a good screening tools. It is helpful in knowing the therapeutic efficacy of the drugs. So due to the wide range of properties, it is called as the a magical biofluid. So just beginning with the introduction, as we all know that this recent notorious coronavirus creating havoc in the worldwide, infecting millions and millions of people. Not only they are infecting the people, but also a wide range of animals too. So they are the single stranded large RNA virus that infects not only human but also the animals. So the virus was first described in 1966 by Tyrrell and Bjorn, who cultivated the virus from patients with common colds. So how to detect this virus, how to estimate this virus? For that, the WHO recommends on 19 March 2020 for the collection of the upper and the lower respiratory specimen. The upper one includes the nasopharyngeal and oropharyngeal swabs, whereas the lower one includes the sputum bronchoalveolar or laryngeoendotracheal aspirate. However, the upper respiratory samples may fail to detect the early viral infection, and the collection of lower respiratory specimen increases biosafety risk to healthcare workers via aerosol or droplet formation. So it's obvious that if there is a more aerosol or the droplet formations, there will be the more transmissibility of the disease. That is what we are seeing in case of the Omicron cases, where they are increasing day by day. So the SARS variant, CoV-2 variant, are characterized by distinct mutation which impact on disease transmissibility, immune escape, diagnostic, and possible tissue tropism. So due to its high mutation rates, it is transmissible, it's communicable, it is immune escape, that is the immune systems can fail to recognize the virus, and there's a tissue tropism, that is that the tissues or the cells gives environment for the nurture of the viruses. So coming this slide, we are talking about how that is the Omicron variant came into existence. As we all know, the virus originated from the southern Africa. There was a three waves. The first wave was associated with the mix of SARS-CoV-2 lineage, while the second and the third wave were driven by the Beta and the Delta variants, respectively. So on 26 November 2021, WHO designated the variant B11529, a variant of concern named Omicron, on the advice of WHO's technical group on virus evolution. What are the characteristics? Coming on to the characteristics, as mentioned earlier, this variant has a high mutation rate characterized by more than 50 distinct mutations. The Omicron variant is exceptional for carrying over 30 mutations in the spike glycoprotein predicted to influence antibody neutralization and spike functions. Also, Omicron has a numerous mutations with increased transmissibility, confer resistance to therapeutics, or partially escape infection or vaccine-induced immunity. So with such a properties, that is the tissue, say that tissue tropism or the immune escape or the communicability from the person to person, one should not take this variant of the Omicron for granted, and one should beware from this variant. On the saliva and COVID-19 was because all we know that saliva is how act as a place of various microflora, including the bacteria, virus, and pathogens. So the same implies for this coronavirus too, that virus transmission from the saliva is unavoidable, especially from the patients who have the respiratory infections. Now, is saliva important? That is what I am going to present from the further slide. That is saliva important from the diagnostic point of view for the estimation of the Omicron variant or other variants. But that is what we are going to see in the further upcoming slides. So COVID-19 can be detected through salivary diagnostic testing, which has a lots of advantage for medical care professional and patients. It should be noted that not only does saliva offers an ecological Nike for the colonization and development of oral microorganism, but also it prevents the overgrowth of particular pathogens such as the viral factors. Also, we have seen that the patients are quite comfortable for giving the salivary samples as compared to that of the nasal samples, or we say that the blood samples, which is quite which can be uh, the quite invasive for the patients, and it is convenient not only to the patient but also for the healthcare workers also. So coming on to the review of literature, here are some studies that I have gone through. So the studies conducted by the Banerjee et al. 2021 for the comparison of mid-turbinate swab and the saliva swab for detection of Delta and Omicron variants of SARS-CoV-2. The study was done on the patients who were acutely symptomatic, non-hospitalized, and were presented for SARS-CoV-2 testing between the months of August and December at the Groot School Hospital COVID Testing Center in Cape Town. Vienna et al. 2021 have illustrated about the rapid expansion of the SARS-CoV-2 Omicron variant in Southern Africa. They described the genomic profile and early transmission dynamics of Omicron, highlighting the rapid spread in region with high level of population immunity. Chu et al. 2021 conducted a study to compare the performance of saliva and mid-turbinate sampling as a non-aerosol genetic procedure with nasopharyngeal samples for confirmation of SARS-CoV-2 infection before and after replacement with beta variant of concern. They enrolled 410 eligible ambulatory participants who presented to Groot School Hospital in Cape Town, South Africa for SARS-CoV-2 testing. Of these, 300 were enrolled before and 110 after replacement of wild-type virus with the beta variant of concern. All participants provided a supervised self-collected saliva and mid-turbinate swab in addition to the standard nasopharyngeal swab collected by healthcare workers. All samples were tested with RT-PCR not targeting the S gene. Umar VZ et al. In the same year have illustrated the reduced amplification efficiency of the RNA-dependent RNA polymerase target enables stacking of the Delta SARS-CoV-2 variant using routine 3 diagnostic tests. Scott et al. In the same year highlighted that the frequency of S gene can be used as a proxy for the frequency of Omicron cases, provided initial detection of local circulation had been confirmed by sequencing. So coming to the results, after crossing to the studies, here I come with the result that the saliva can be a good diagnostic tool for the determination or the estimation of the chronic system or the local diseases, oral diseases. It acts as a mirror for the estimation of the general health or oral health. Also, then the positive percent agreement of the saliva swabs with the nasopharyngeal swab from the beta variant of concern increased by 21% from 51, that is from 51.5% to 72.5% from before to after variant replacement, whereas the positive percent agreement for the mid-turbinate swab related to the nasopharyngeal swab remains similar, that is the 75.8% before a replacement and 77.5% after. You can say it's quite a negligible. The reason for the significant improvement in positive percent agreement for saliva but not mid-turbinate samples are currently unclear. Investigations are required to explore the potential of saliva for COVID-19 detection in both symptomatic and asymptomatic patients. The saliva is also a good tool for the detection of the Omicron variant. So, whether we should go to saliva swab or the mid-turbinate swab, which one will be the better? So for that, the study was conducted in the University of Cape Town in Southern Africa by Banerjee et al. So they compared the saliva swab and the mid-turbinate swab by taking the two variants, that is the Delta and the Omicron variant. So when they test saliva with PCR for virus, in Delta only 71% test positive, whereas for Omicron it is 100% test positive. That is, there is more Omicron in saliva as compared to that of the nasal swab. Contrary to it, in Delta variant there was 100% test positive, whereas in Omicron variant there was 86% positive using the mid-turbinate swab. So here the scenario is different. In case of the mid-turbinate swab, there is more Delta variant than the Omicron variant. The Omicron variant of concern shares a spike deletion 69 to 70 with alpha, which has dropped to negligible levels worldwide. Therefore, the frequency of S gene results can be used as a rapid proxy for the frequency of Omicron cases, provided initial detection of local circulation has been confirmed by sequencing. So coming to the conclusion. So as we all know that the patients with the coronavirus diseases is having the hyposalivation and altering taste disturbance. Also, after crossing through the studies, here we also conclude that uh, we cannot come in a point where we can say the actual chemistry between the saliva and the salivary gland from the disease construct, or to find the real pathogenesis of these variants in the saliva or the salivary point of view. Also, we have seen that was a increase in the positive percent agreement in mid-terminate swab from beta variant of concern. The significant increase is also currently unclear, and at this present moment. However, they could increase the change in tissue tropism linked with a variant of concern. Also, there was more Omicron variant in saliva. The pattern of viral shedding during infection is changed, with more viral shedding in saliva as compared to the nasal samples. The pattern of viral shedding and its implication for diagnostic sample procedure are currently unknown at this time. In human bronchus, Omicron has been demonstrated to infect faster and more efficiently than Delta, but with a less severe infection in lungs, resulting in symptoms such as sore throat and less loss of taste and smell, which are better detected by saliva than nasal swabs. So we have seen in studies, it is seen that the patients who have infected with the other variants, such as Delta or the Beta variants, these variants are generally dwells in the alveolus part of the lungs, where the exchange of gases takes place. Whereas in the Omicron variant, that this dwells in the bronchus part. So as the more aerosols are created, they are easily transmissible from person to person. They are easily communicable from one person to another, and that is what we are seeing, that the cases are increasing day by day. So here are the references that I have gone through. Thank you. Be safe. Jai Hind.